I'm very pleased to be able to introduce my friend Bernard Ewigman. Dr. Ewigman is professor and chair of the Department of Family Medicine and at the Department of Family Medicine at the Pritzker School of Medicine at the University of Chicago. He's also the Owen Kuhn Endowed Chair of Family Medicine and Director of Outcomes Research at the NorthShore University Health System. There's only one of him, but I think he has about 3 jobs. He has nearly 40 years of experience conducting research, training research fellows, serving in leadership roles in research programs, centers, and institutes. He currently serves as the chair of the steering committee for the Building Research Capacity initiative sponsored by NAPCRG and the Association of Departments of Family Medicine. Dr. Ewigman has served as PI, co-PI, or lead for about $60 million in direct costs and has published over 80 manuscripts reporting original research, systematic reviews, or editorials in leading journals like the New England Journal of Medicine, the American Journal of OB-GYN, and the Annals of Family Medicine. He was recognized with the 1995 Pew Primary Care Achievement Award for Most Outstanding Primary Care Researcher in the U.S. Currently, as an endowed chair, Dr. Ewigman devotes time to the development of programs, mentoring researchers and research leaders, to research capacity development in primary care, and to scientific editing. Welcome, Dr. Ewigman.
Good morning. Good morning. Thank you, Mark, for that very nice introduction. I do have to add a little caveat. The Pew Primary Care Award for Most Outstanding Researcher in the United States, that was a long time ago. And actually, at that time, there were only 3 primary care researchers, and 2 of them had already received this award, so I was the only option. Now, I appreciate Judy's comments, a nice segue to what I'm going to talk about, BRIC and the Building Research Capacity Initiative, but I was thinking about when was my first NAPCRG meeting. I believe it was 1980. If she was a child, then I was a baby when I came. So, let me get the logistics figured out here. The big green one? Okay, very good. So, when did we decide to do research in family medicine? When did it all begin? What was the beginning? More importantly, why do we do research and why do we build research capacity? How important is it to our future? How much progress have we made and what's our role going forward? It's hard to say where things started, lost somewhere in history, but I think it's safe to say that the general practitioners from Great Britain, the United States, Canada, the Netherlands, and other countries were the progenitors of family medicine research. And for general practitioners, family physicians, and primary care clinicians, the question that we always ask with every patient is, how can I be helpful? How can I help you? I want to make the case that we draw from that same wellspring of values as researchers. In our case, it's, how can I do more because I've failed you? I failed in the present. How can we do more for the sake of future patients like you or future communities or populations? I'm going to use the Curtis Hames story, but before I move on, I wanted you to notice the brick, the logo, and I'll explain that as we go along. I'm going to use the Curtis Hames story to start. Many of us here have been inspired by this story. Curtis Hames started practice in 1947 in his hometown of Claxton, Georgia. He saw up to 50 patients a day, took care of patients in the hospital, home visits, like the ordinary general practitioners of his age. However, Dr. Hames had an extraordinary life. It was studded with discoveries and innovation that arose from his practice observations. Through careful observation of his black patients, he noticed that coronary artery disease was less common despite the fact that they had higher rates of hypertension. Dr. Hames' drive to look at what he called the big picture led him to develop the Evanston County Heart Study. This longitudinal study led to multiple insights related to modifiable risk factors for heart disease and stroke. His work, along with the Framingham study and thousands of other investigations, have led to dramatic declines in mortality and morbidity from heart disease and stroke. This slide shows a revealing quote from Dr. Hames. A true physician should bring to the suffering patient a quiet sense of humility, dignity, confidence, and security based on the conviction that all will be done that can be done. Curtis Hames engaged in research because he was curious, because he wanted to serve his patients and his community, and to live out his deep conviction that all will be done that can be done. His life, his accomplishments, his personal journey, and the research capacity that he built were all driven by something inside his true self, some intrinsic motivation, which is a sine qua non for all researchers. So my point here is that building research capacity always begins with curious, committed investigators like Curtis Hames. In fact, everything starts with curious, committed investigators who want to help, who are not satisfied with the status quo. There's really only one reason to build research capacity, and that is to provide investigators with the capability to do more, to pursue the questions and the problems that they cannot solve at the point of care or in their communities. Now, family medicine research family medicine and research were almost mutually exclusive terms at the time I was in medical school and residency. There just didn't seem to be a connection. And there were very few researchers. There are some exceptions. Carol Herbert, one of the early family medicine researchers, a past president of NAPCRG from Western Ontario University in Canada, wrote in a tribute to Maurice Wood that NAPCRG is the family of family medicine researchers who were few in the 70s and 80s and often isolated in our own communities, and Maurice was the dad. Now, this photograph was taken in 1977. It shows Dr. Robert Smith, another general practitioner like Dr. Hames, with a patient. And that tall, handsome guy there is me on my preceptorship as a third-year medical student. I just heard someone say, "That doesn't look anything like him." Well, if it is him, at least he's still tall. So I was able to have a very rewarding career. I was able to practice full-scope family medicine for 17 years and train family physicians like my family doctor, Dr. Smith. He delivered me and most of my 35 first cousins. I was also able to have a very rewarding academic career. And this man, Jerry Perkoff, gets the lion's share of the blame, or the credit, depending on your perspective, for steering me into academics. He left a tenured professorship at Washington University in 1979 to come to the University of Missouri, where I had started my internship in Columbia. And he was assigned to me as my research advisor. Now, there's a big city internist, and for me, Dr. Smith was my hero. He still is. He's my ideal of a great doctor. And my goal was to become a rural family doctor like him. Well, so big city internist is assigned to aspiring country family doctor. It made no sense at the time. But he brought, along with many other faculty at the University of Missouri, an intellectual rigor and a focus on patient-centered care and a evidence-based medicine of a type that was, hadn't been named yet. Those were terms that didn't exist in those times. But he led us all to ask questions, to challenge, and to take the next step, to use research evidence to actually take care of individual patients. So following the residency, I completed the academic fellowship at the University of Missouri that Dr. Perkoff directed. That was his main role coming to the university, was to lead a academic family medicine fellowship. By now, there's been hundreds of family medicine researchers who've had formal research training, including most of you in this room. Dr. Perkoff remained as my primary mentor after I stayed on faculty at the University of Missouri. I'd like you to just contemplate for a moment the impact and the influence that role models and mentors have had in your life. Their courage, their boldness, their life as examples, they're willing to give generously and challenge you, can be life-changing. And this certainly was for me, and Jerry Perkoff was a life-changing influence in my life. Each week we met with Jerry, and we had to design an original research project to complete the fellowship. And one week I brought my latest idea to Jerry, and I explained that ultrasound screening in pregnancy really had never been evaluated as a test. There had never been any studies. And then I said, but that would require a large randomized trial, and as a fellow, that's totally unrealistic, so I can't do that. His response was brief and direct as usual. His immediate response was, why not? I said, well, you'd take a large sample, you'd have to recruit all sorts of patients. I'd have to recruit every doctor I know to do this. He said, have you tried? Have you tried to recruit those doctors? I said, no. Why not? Why haven't you tried? And I admit that kind of caught me off guard. I can't recall what I said. I don't know if I even answered. But what I can tell you is that conversation stimulated me to pursue something that I thought was totally impossible. 3 of us ultimately completed the first randomized trial of routine ultrasound in the United States. We somehow managed to recruit every physician in the county to participate in the trial. However, 915 patients turned out not to be an adequate sample. And we'd done it on a shoestring budget as fellows. And now, while this study was going on, the NIH had convened an expert consensus conference to address this issue of routine prenatal ultrasound screening, because people were beginning to do it. We didn't even know about it until the recommendations came out, but we were in the process of this study. And the bottom line was they concluded that a large, definitive, randomized trial needed to be done in the United States. So we got excited. I went to Jerry. I said, I want to do this. How do I do this? I mean, how could we? I mean, we need probably over 10,000 patients really to test this hypothesis with adequate power. That doesn't seem possible, but I had learned not to say that things are impossible. So how could I do this? The answer was very brief. Submit an R01 application to the NIH. My response, what's an R01 application? He gave me a copy of the instructions. Now, and this is before computers and the internet, so it was a pretty thick and intimidating set of instructions. But the RCT that we eventually completed was conducted in 6 states, took 5 years, enrolled more than 15,000 patients, cost $12 million, and the findings were published in multiple journals. We established the diagnostic effectiveness in the real-world office setting of routine ultrasound in low-risk pregnancies. We also definitively showed that it made no difference with perinatal outcomes, either for the mother or for the baby. There was also no adverse effects of doing routine ultrasound. So the point here, and I'll come back to the ultrasound study, is that curious, committed investigators need role models and mentors. But back to the study. U.S. rates of prenatal ultrasound in low-risk patients in 1993, when we published our study, were less than 1 per pregnancy. By 2015, at least one study shows that there's 4.7 per pregnancy. So the rate has steadily risen. And I think the lesson here is that despite clear evidence regarding biomedical outcomes, the preferences of patients, the experience of care, the information that one can get visually as well as in measurable terms, very important to patients. And patients obviously are choosing this, and physicians as well. The point I want to make about this as a researcher is that we cannot control our results. We can control what we do, our design. We can be creative, and that's the fun part of the process. But we cannot control the results, so we can't get married to our results. Our satisfaction cannot depend on what we can't control. Not only can we not control the results, but we can't control what people do with them. And it stifles creativity to be too focused on what you're going to find and what you're going to impact. Obviously, we want to do good. We want to help people. But the research process, you don't know what's going to happen. Otherwise, it wouldn't be research, right? So let me just reiterate my point about curious, committed investigators need role models and mentors. We need collaborators. We need participants. We need equipment, space, resources, funding. There's a lot of capacity that's needed to really answer these questions and do more for our patients. Without Jerry Perkoff, I would not have started down this path. No question in my mind. I would have been a rural family doctor. Not that that would be a bad thing. And I wouldn't have stayed on this path without him and other role models and collaborators. It really is a group effort. It really is a team sport in family medicine. Now let me move to another story. This is a very different story. This is about a dying child. And sometimes, in this case, the results were actually very gratifying. Our department faculty staffed a clinic in a public health department for uninsured poor families. We cared for a lot of children who were developmentally delayed, abused, neglected, and had other serious problems, a lot of family violence. I'll never forget one infant that one of our public health nurses had gone on a home visit and discovered this child, was 4 months old, brought this child to my office, and this infant was emaciated. Both of the buttocks of this little child this infant were ulcerated from having been left in the feces for a prolonged period of time. The baby was hardly responsive. The baby was dying. Now, not too long after that, there was a national conference, the Child Maltreatment Fatality Conference. There was no data nationally at this time. And again, this was in the 1980s. How many children die of abuse and neglect? You'd think you'd know that, but we didn't. So every state was asked to come to this conference and report how many children die of maltreatment in your state each year. Well, the state of Missouri Health Department reported 6 deaths. Now, we couldn't believe that was accurate, just in our medium-sized county based on our clinical experience. And so we pursued a study, Missouri Child Fatality Study, in which we determined that half of the children that had been reported as accidental deaths, in fact, had been abused, neglected, or died from some other non-intentional or some other injury. These deaths were preventable. At least theoretically, they were preventable. For that reason, we lobbied the Missouri State Legislature, and we lobbied them to create child fatality review panels modeled after the maternity panels of many decades ago that helped bring down maternal mortality, mandated a data collection form that our research team had created. It's It's a good way to get a good response rate by legislating data collection. And then we got a grant from the Centers for Disease Control to create a surveillance system, the Missouri Child Fatality Surveillance System. All of these things began in about 1992. And data was collected. Our research team continued to conduct epidemiologic studies to define the high-risk populations, to identify modifiable risk factors. We engaged in child maltreatment and injury prevention studies, including randomized trials. Now, all of this was integrated into a statewide program called the Missouri Child Fatality Review Program. And the implementation, which focused on determining cause of death with a multidisciplinary panel, and the implementation of prevention strategies across the state. Now, this work has gone on for 36 years now, and though I have not been personally involved since I came to Chicago in 2002 from Missouri, but I did find this annual report online in preparation for this talk because I was kind of curious. I wonder what happened to that. Well, it turns out that, remarkably, the number of child fatalities in the state of Missouri has gradually declined by several hundred per year over the last couple of decades, despite a stable population in this age group. No doubt this is due to multiple prevention efforts at the local, state, and federal levels. So back to being a doctor, yes, we could and did admit those children who were injured or failing to thrive to the hospital. But by that time, it's really too late. The damage is really pretty irreversible at that point. We wanted to do more. We wanted to do much more. Seeing these children and feeling so frustrated as a physician, knowing that these parents love their children, despite the fact that they may be failing grossly as parents. One of the things I've learned through this is that every parent loves their children, wants to love their children, and can't, in some cases, for a variety of reasons, often their own trauma experience. So we did more. We did a lot more, and it took a lot of capacity. Capacity building is a very important part of getting research done, getting results, and seeing them enacted in the real world. Now I want to move on from these stories, which I hope have given you a flavor of where I think building research capacity comes from and why we do it. This rough graphic presentation of my career over 33 years, from 1985 to 2018, kind of parallels the development of family medicine research in the United States. In 1985, Larry Culpepper, who many of you know, did a survey and found that there were no family medicine departments or physicians in the United States who had an NIH grant, 0. Now this is about 16 years after the specialty was created. Family medicine in the United States, and I think most places, is a quintessential clinical specialty. We just recently completed a study, and we're going to present the results of this at 9:30 in Stevens Salon A3. So I'm not going to give them away. But one of the points I'm going to make is that by 2015, when we completed this study, there were 50 departments with NIH funding in the United States. That's tremendous development, tremendous growth. And I don't mean to call on the NIH as the marker of productivity, but it is a good marker, and there's many other measures that we'll communicate in our session at 9:30. There's been a lot of capacity building. In my own career, I spent the first 8 or so years, 10 years, really developing my own personal research capacity. Mentors, colleagues, funding, all of the things that many of you who are just beginning in your career are attempting to do, or if you're in the middle of your career, you've done it and you're on your journey. But at that time, there were very few senior investigators. Jerry Perkoff retired in 1991, and my chair asked me to become the research director 6 years after I started as an assistant professor. Now, this turns out to be pretty common in family medicine. Turns out that the way to approach research capacity building in those days was hire somebody who's willing to have the label research director and ask them to do it, but don't pay too much attention to them. Now, that was not true for me. I had a lot of support, but that was unusual. So I began to develop research director workshops and later capacity building workshops for chairs and research directors, because it became very obvious to me that there were a lot of smart people in family medicine who wanted to ask and answer questions, but there were very few places to do it. So my 33-year time span roughly parallels this development that we're going to talk about later. The point I want to make here is that we have had to build a lot of programs, fellowships, research centers, departments, funding, training programs in order to get where we are today. And we've made a tremendous amount of progress in the United States. Now, Canada is way ahead of us, and I'll mention that later and show some data at 9:30 that illustrates how far Canada is ahead of us in terms of having really robust research departments compared to the United States. So what does it take to do this? It's actually extremely complicated, very challenging. There's many, many elements. And the Family Medicine for America's health team has done a spectacular this team has done a spectacular job of surveying the landscape and mapping the research capacity efforts that are going on in the United States. Now, this is a very busy slide. I don't expect you to read it. You know, one slide may be worth 1,000 lectures in this case. But the point I want to make is that they've classified all of these capacity building activities on what would be the let's go back. I had the wrong slide. All right, let me start again here. This slide is very busy. That last one wasn't so busy. And I don't expect you to be able to read it. But as I said, a slide can be worth 1,000 lectures. And the Family Medicine for America's health team has done a great job of mapping research capacity building efforts across all of the family medicine organizations. And they've color-coded it. They've color-coded it into 6 categories of research capacity building. And I'm not going to read that. Most of you know what you can imagine what goes into this. And then they've listed the 8 organizations. And that beautiful infographic in the middle shows us what each organization is doing in collaboration. Tremendous amount of work going on. And obviously, I'm not going to go into details. I'm going to stick with the personal journey and not regale you with everything. But it does remind me of Carl Sagan's recipe for apple pie. He said, if you want to make an apple pie from scratch, you must first create the universe. Well, it's kind of easy to feel overwhelmed by all of this, isn't it? Yet, if we want to have a meaningful collective impact on improving health and healthcare, we have to do this. We have to build capacity. And fortunately, the universe has already been created. We don't have to start from scratch. None of us have to start from scratch on anything. We just have to recognize that we have the ingredients. We have all the ingredients we need. We need to use them, work together, help each other to accomplish what we need to accomplish. So you may have noticed these little bricks down there in the corner of the slide. You may have been curious about that. I'm going to explain that now. So there's a well-known parable, many of you have heard this, about bricks and bricklayers. There's a traveler comes across 3 bricklayers. And they ask the first bricklayer, so what are you doing? And then this person says, I'm laying bricks. Comes across the second bricklayer, and what are you doing? I'm building a wall. Then he comes across the third person and asks, what are you doing? And the answer is, I'm building a cathedral. Now, the first person was completing a task, the second one had a goal, but the third one had a calling. And we have a calling as physicians, as researchers, as investigators, and we have a calling to build research capacity. So how have we done with that? This is where there's been a variety of studies that have been done in the last several years that collectively really paint a reasonably complete picture of the state of research in family medicine in the United States and to a certain extent in Canada. One of these studies was just published. It was presented by Winston Lau at this meeting as well, published in Family Medicine. And what they did was do a sort of a mixed method approach, snowballing, looking at objective evidence of great research capacity, interviewing people, asking for opinions, and coming to conclude that there was these 8 departments of family medicine in the United States that were bright spots. Now, this came out of the Family Medicine for America's Health. One of their objectives was to try to say, where are the bright spots? What do they look like? And I'll just give you a flavor. You can read it online, but the mean number of faculty in these departments are 90. These are big departments, and I think that's a key point. You know, I think in family medicine we have to have that clinical base. We have to have patients to take care of and communities and populations to take care of, because that's our research. We also need to have on top of that our training and education. And when you think about it, research is kind of high on Maslow's hierarchy. These departments have achieved mean NIH funding over a 5-year period of about $13 million each. Now remember what Larry Culpepper said in 1985, 0. So from 0 to 13 million over a 5-year period, I think gives you a sense of the progress that we've made. Now this next slide is my attempt at combining a whole lot of data into one visual graphic. I didn't do quite as good, I don't think, as Family Medicine for America's Health. But we're essentially trying to build cathedrals in family medicine. We're trying to build cathedrals that will allow investigators to be successful and do what they need to do. And a cathedral, I think, is an apt metaphor here. The medieval cathedrals, particularly the Gothic cathedrals, reflected the worldview of the communities that built them. They were intended to be quiet places, sacred places, places in which order, in which beauty, in which truth were represented in stone and glass. And these are places where people could retreat from the chaos of the world, re-energize themselves, in a sense, be mindful, if to use modern language, and have that energy to go back in the world, live our lives, do our work, and fulfill our purpose. And as researchers, our purpose is to ask, how can we help? And how can we help more when we're failing in the present? How can we help future patients like you and future generations? Now, how have we been doing? So what this represents is our research capacity survey findings, the bright spot studies, and a little bit of mixing and matching on my part. So don't take these numbers too seriously, but I think it gives you the sense. So we categorized, these are all the departments in the US and Canada that were in our study. And there was 109 US departments, 13 Canadian departments. Of those, 51 were put in a category of no research or low capacity. And that's the image there with the very small foundation of the cathedral. We have a lot of departments that are doing very little, just getting started, or maybe have no intention to do any more. In the second category, we have those departments that are what we call moderate capacity. They may have 2 or 3 investigators. They may have a couple of grants. They're doing it. They're successful, but boy, one of them leaves or they don't get funding. It's not a sustainable situation. There's about 24 that we put in that category. And then there's the high capacity departments. Now, this is where I've exercised some creative license, and I've taken out the 8 bright spots, and because the majority of departments in Canada would be in this high category, I just assume, okay, there's 4 bright spot Canadian departments. I don't know whether that's true, but I'd love to know. But for now, just bear with me and assume that we have 12 departments between the U.S. and Canada that are starting to look like real cathedrals, starting to look like places of supportive environments, places where people could go and thrive and be productive. And that leaves 25 high-capacity departments. So we kind of define that as departments that we think a pretty good chance are going to sustain. They had at least 4 full-time equivalents, researchers. They had external funding. They had a strong mission related to research. They had all those elements that we know are important for successful research organizations. So at this point, you must be wondering, gee, this is all very complicated, takes a lot of time. How are we going to do this? Well, the first thing I'd say is that every one of you, every poster at this meeting, every presentation has a story like mine, a beginning, a middle, and an end. And you are building research capacity, and I'm sure you have built programmatic and departmental research capacity in order to fulfill your research. So we're going to keep doing that. But how? How could this building research capacity, this brick, possibly have any impact on building cathedrals? You know, cathedrals take 50 years to build, 100 years to build. It takes a long time. Well, Carol Bland has laid out the architectural plan for us to guide our building. Carol Bland was a PhD at the University of Minnesota, very committed to research, family medicine research. I think it would be difficult to overestimate her impact. She literally wrote the books on highly productive academic departments, as well as the characteristics of productive researchers, and on effective faculty mentoring. Her work, even though it takes books and journals to describe, can be boiled down to 3 sentences. Well-prepared individuals go into a supportive environment. A supportive environment facilitates productivity when its leaders attend to the features that enhance that productivity, and a conducive environment, building a conducive environment, is the result of effective leadership. Now, I've highlighted the fact that leadership is the key ingredient here. There's lots of other ingredients. She's got a really nice, logic models and all that with lots of details about how to do this. But the bottom line is it takes leaders. It takes leaders to build research capacity, just as it takes architects to build cathedrals. So how is BRIC using this? How are we moving forward? Well, we conceptualized this 4 years ago. This was a joint initiative with the NAPCRG Executive Committee and the ADFM Research Development Committee. I see many folks in this room who were involved in it and have been involved for the past 4 years. We officially launched this 2 years ago, again, with the active support of the NAPCRG board, and I thank you for that, and the active support of the ADFM board, the Association of Departments of Family Medicine. The focus of BRIC is on leadership education, coaching, and information sharing. BRIC exists to assist research leaders to build research capacity in whatever way they need assistance. We do this through multiple ways. We have presentations at all of the national meetings now in the United States. We have dedicated program time for individuals, chairs, research directors, program directors, research faculty. We will provide coaching and advice in a formal consultation arrangement. We have an assessment and evaluation project as a formative process to figure out what does the community need, how can we help, and how are we doing? Are we meeting those needs? It's an evolving, iterative, living, learning community. We also actively collaborate with multiple organizations and who share a mission, share our values. If we find something that we can do together that's going to be mutually beneficial to build capacity, then we figure out how to do it. Now, I'm not going to go into the details of the organizational structure or how we run things because there's dozens of people involved, lots of activity happening. But I do want to just lay out the leadership teams and the leadership, the people who are the leaders of BRIC. I am the chair of the steering committee. C.J. Peak at the University of Minnesota, Tony Kuzel at Virginia are co-chairs of the consultation work group. Lynn Meadows from Canada is the assessment and evaluation chair. Our curriculum work group is led by David Snyder and also Dana King. David's in Texas and Dana's in West Virginia. And we have really terrific administrative support. People kind of working overtime, really, from Artis Davis and Tom Van Senge, the executive directors of these organizations, and then Hannah Bruins. And I'm going to stop there and just say that Hannah Bruins is the person to contact. She's the glue that kind of keeps this virtual learning community together. So if you're interested in getting engaged or being engaged in any way, she's your best place to start. Now I'm going to wrap up. And I want to wrap up on a note of hope about the future. And this has turned out to be quite easy to do. Last Friday, NAPCRG sponsored a Rising Stars pre-conference, Rising Stars in Research. And myself and several folks in the room had the opportunity to serve as the mentors for these students, graduate students, medical students, residents, and fellows who wanted to get some information. And so we spent the better part of a day together, and it was quite fun. There's a saying that where there is youth, there is hope. Now, you'll be pleased to know that our Rising Stars are a diverse bunch. They're enthusiastic, they're smart, and have very interesting ideas and projects. I started my presentation from the perspective of a clinician, a family physician. When we see patients, we ask, how can I help you? I'd like to end my presentation speaking for all of the leaders in BRIC, in the Building and Research Capacity Initiative, by asking, how can we help you, and how can we help each other? Thank you. Thank you very much. Happy to take questions. Yeah. I don't know if are there microphones? Yeah, there's microphones. It looks like there's 2 of them right there in the middle of the room. So very happy to hear comments, take questions, etc. So let's start with Kurt Stange.
Thanks, Bernard. I think your example of the work you did on infant maltreatment is inspiring. So you did the work, you went on and did other things, and you look back at what happened, and great stuff had happened. So that's a great example of generativity. I want to actually, though, suggest a different way of understanding the work you're doing with BRIC. I love going to cathedrals. They're inspiring. But when I notice when I'm there, it's mostly, there aren't very many worshipers anymore. They're mostly filled with tourists. And I think actually the work that you're doing, these large departments that you're talking about, are more like the large trees in a forest. And they're creating a lot of seeds. There's also a lot of other stuff going on in the biome. And I think what you're doing with BRIC is actually doing a lot of stuff to create the seed bank. So I think we're ready for a big fire here. And if you look at what happens ecologically in that kind of environment, we put all these resources into the big trees, a few of them will survive. Most everything is wiped out. And in that environment, we want to make sure we have a good seed bank there. And we want to nurture a whole bunch of different seedlings so that when there's actually light in a way that there isn't now on the forest floor, that we have a lot of different seedlings there. So we need a few of the big departments that can create some big seeds that'll seed more of the old way of doing things. But what we really need is to make sure we're nurturing the seed banks so we can have a lot of diversity and having ground up things. And that's likely to happen in partnerships with others in our biome.
Thank you. Thank you. Larry.
Bernard, thank you very, very much. Thank you for your persistence and your leadership. I want to go back to your slides about Curtis Hames and also your work in Missouri, and ask you to talk a little more about something. You showed a slide of Curtis with the county health department around the art project. And I think in this journey that you reviewed today, one of the things that has happened occasionally was the union of that personal physician bending over the bedside saying, "What can I do for you today?" with the public health community. And I think you are a role model of that in some way, and you exemplify this, this union. If Curtis could stand in the room today, he would say, "Why the hell did these ever get divided in the first place?" And you put them back together, and could you just comment about how you've done that and what you think about it?
Thank you, Larry. Do you have was there a question there, Larry? Or was that no? If you ask a question, I missed it.
Yeah, I ask you to say more. Would you please, Bernard, say more about how you personally have put together working with health departments while working with clinical settings,
Yes.
while working with medical schools and departments and that sort of thing. How have you managed to pull those unfortunately bounded entities into coherence in some way to actually do things that improve health?
Okay, good. I got it. So the question is, Larry's asking how I was able to both live in the world of seeing patients and be a personal doctor, but also bridge that to the public health world. And it's a great question. It's not an easy thing to do. In the United States, public health historically got divorced from medical care, and it has had a big impact, I think, for ever since that happened in the early part of the last century. I guess there's a lot to say, but several points come to mind. First of all, my base was always as an academic, as a professor. And so I had this stable job in a department that valued what I did. They valued that I practiced, and they valued that I did public health or research or whatever it was that I thought I needed to do. And there was no judgment about where you practiced or how you did your research or what topic. It was just supported. And so from a logistic point of view, what I would say, Larry, is that while I always had my income from an academic department, there's never been a time in my career when I didn't have another job. So initially I was the director of the county health department, and I did that for about 4 years. After I went on a sabbatical to the NIH, I came back and I started a federally qualified health center. And so I became the medical and executive director of that and practiced there. That led to a community health improvement project. It led to geomapping. Bob Phillips was one of my fellows. He practiced with me there. We did a geomap with a medical geographer of the community, and we found this little pocket of people who were eligible for our FQHC but weren't using it. It turned out to be the housing authority. So Bob and a nurse practitioner set up shop there. That's where Bob got his bug about geomapping and what led to health landscapes and all of that. Of course, having an understanding of population health, community health. So I have a master's in public health. I mean, and just knowing that's part of our job. It's not just not just the person in front of us. It's our community. Whatever it is that community needs. It's just like seeing patients. You know, every family physician in every community adapts to what their patients need. I adapted to seeing kids. 50% of my practice was pediatrics, for goodness sakes. I was out of my league, and I'm very thankful to have pediatric subspecialists at the Children's Hospital to help me out. Rural doctors do a lot. Urban doctors focus more on outpatient care or segment their practice. The same thing is true of communities, of populations. You have to respond to the community, and in order to respond, it seems to me you have to have two things. One, you have to have the tool set, which is epidemiology, social sciences, to understand, organizations, culture. But you also have to have the opportunity. So many of us have no time. We'd like to do this, but there's no way to fund it. And the way I've done it is I got an academic base, and then I go find jobs, and people are willing to pay me to do it. So then my department's very happy with that. So I think that's probably the two key things. Other questions or comments? Yes, Jim. You may need to come up here because I don't be able to hear you. Oh, here's another microphone.
I'm Jim Mold from Chapel Hill, North Carolina now. I retired in 2014, so I apologize if I'm out of touch and don't know what's going on. But when I became a research director in 1995, the University of Missouri, under your leadership, had a fellowship program to help departments develop research capacity. I came for a couple of days, 2 or 3 days, went back, and then we had a second session where I brought my chair, my department chair, for a day or two to learn what it took to develop capacity in research. That was the most important thing I ever did with regard to learning how to develop research capacity within my department, and I thank you for that. And I'm asking if that kind of thing still exists, or whether people still think we need programs like that, and how did you fund that, and so forth.
Well, thank you for those kind words, Jim. That's very gratifying to hear, especially coming from someone like you. The question is, does that resource exist? So the Missouri Research Workshops were in the late 90s, mid-90s, late 90s, early 2000. We had about 30 departments, came for 3 days, and it was really a group process in which each of the 6 departments, first of all, had done a lot of preparation in advance, an environmental scan, a SWOT analysis, and then came